So do we really need to have more than 5 years of hormonal therapy? Isn't 5 years enough? And, you know, it's always easy to prescribe a drug. It's a lot harder to take it. And I have to say, like, after I became a patient, the first thing I did is realize, like, oh my God, I've been really a bad doctor for so many years. But I think we as physicians, we need input from your side, and we need to understand, like, what the implications are of drugs, and so we can really do this back and forth. Is like, I mean, yeah, these are the side effects, but these are the benefits, and I think everything in life is a risk-benefit ratio. If you have a high risk, you should really try to deal with the side effect as best as you can. If you have a low risk, maybe you can forego that. So who needs hormonal therapy? 70% of all breast cancers are estrogen receptor positive. That means, like, they actually benefit from hormonal therapy. Hormonal therapy, we know, saves lives, but it can also make life hell. So how do we find out what to do best? Tamoxifen, 5 years versus not, is like, this is all data, and what we're looking at here is like the graph of the risk of recurrence. If you had cancer over the course of 15 years, this is what the risk of recurrence is. And I think what's really important, and that's the part where if you only take one thing with you, is like, unfortunately, if you have estrogen receptor positive tumors, your risk of recurrence does not go away. If you have triple negative breast cancer and you haven't recurred within 3 years, you're probably mostly fine. But in ER positive tumor, that's actually not the case. It's like, so recurrences continue, and they continue through the course of 15 years. We give tamoxifen. We give tamoxifen for 5 years, and the benefits continue. The benefits are here. But the risks continues, and the differences actually stay out. So we do see benefits from tamoxifen. So you see a significant lower number of women who got tamoxifen recur at 15 years than those who don't have tamoxifen. If you look at the benefits of tamoxifen or hormonal therapy, and these are like oncologists, we don't have any cool pictures to show, like, so we do a lot of graphs. This is what we call is a forest plot, and what we see is like who is actually the person who benefits. And what we're looking at here is like, I mean, site of first recurrence. So if you have a tumor coming back, where does it come back? It's like isolated means like in the same breast, contralateral means in the other breast. Or distant or multiple tumors. So as a medical oncologist, we actually worry a lot more about what happens like systemically, if the tumor comes back in the liver, in the lungs, or in the bones. But what we see here is like, and that's what these dots do, is like smaller dots means like a lower number of patients. The majority of patients who have a recurrence actually have a distant recurrence. So tamoxifen does much better. Anything that's to the left of this line is meaning better with tamoxifen. Anything to the right of this line meaning no improvement or worsening with tamoxifen. And what you see here is like everyone benefits. Those with there's fewer numbers of recurrence in the breast, in the other breast, or distance. And this is what I said before, is like if you're estrogen receptor negative, look at the pink line. The risk of recurrence is really high. On the first 2 to 3 years, but then that sort of like decreases and always goes way down. If you have estrogen receptor positive tumors, that risk of recurrence is actually still fairly high out here, twice as much as those with ER negative tumors. And again, in tamoxifen, anyone benefits from tamoxifen, regardless, small tumors, big tumors, young women, older women. Tumors with lymph node involvement, everyone really benefits. I mean, tamoxifen really works. It may not be pleasant, but it does work. So do we need more than that? Initially, and we actually don't really know what happened, but initially there was a study suggesting that tamoxifen beyond 5 years did worse. And whether it is actually was one of these rare occasions where people messed up the arms and actually really showed the wrong arms, or it's just a small study, but for almost 15 years we stopped tamoxifen after 5 years because we thought it would make it worse. And I had so many patients walking into my clinic at 8 years with the tumor spreading to their bones, saying like, oh, I was on tamoxifen for 7 years, I stopped it, and now my tumor is back. So many of us felt like maybe it is not worse, and like so this question was reevaluated after this initial data. So there's two large trials. One is the ATOM trial and one is the ATLAS trial, and this is looking at the long-term effects of continuing adjuvant tamoxifen for 10 years versus stopping at 5 years, and this is done in 6,953 women. And I have to say, when this data sort of like broke, unlike the plastic surgeon whom everyone loves, the oncologist, we don't get as much love as our as our colleagues from surgery. We did not make any friends. When this data broke that 10 years of tamoxifen is better than 5 years, a lot of people came in and said, Jesus, we don't want to do that. But the reality is, like, you don't have to do it, but you have a choice, and you should consider that choice. So this looked at a large group of patients in collaboration with an international counterpart, the ATLAS trial, and this is now a worldwide trial, looking at more than 20,000 women, and deciding whether tamoxifen for 10 years is better than 5 years. And as you've seen before, it's like we need to have that long follow-up. We need to know at 15 years because the benefits last longer, so we may not see them initially, but we may see this later. So that's an enormous effort to follow 20,000 women for 15 years. And that means, like, we have to actually stay in business, because if you retire, we can't really follow your data. And that really points to the fact that the initial NSABP 14 trial only looked at 1,500 patients. So the negative result of that trial is probably really drained out by now the really significant number of patients of the ATLAS and the ATOM trial. And off the bat, you see, like, these actually don't make it to the 20,000. It's like close to 17, but still it's a fairly large trial. And then when we look at who benefits here, so again, our fabled forest plot, and if you look here, anything to the left is a benefit, and if it to the right is no better or worse, and the midline is sort of like means like it's equal. If that line that gives us our confidence interval crosses the midline, we may see a result, but we're not confident that what we see is really what we get. So you remember when we do statistics, if you do the same thing over 20 times, the likelihood that you see a result that you like just by chance is by our p-value is 1 in 20. So we want to have a p-value of 0.05, and here this is the two-sided p-value of 0.003. Looks like if you look at all comers, looking at tamoxifen for 10 years versus 5 is better at 15 years. But it's sort of like, it's just borderline. So again, if like the benefits are there, and you look here, the benefits are small. This is but there's a 3% difference in death rate from 10 years versus 5 years of tamoxifen. So in the way I look at this data is like, if you're a patient who is 5 years on tamoxifen and you have no side effects, you should stay on, because the chance that you do better is high. If you like every day think like, God, I'm not going to really want to do this, and you start thinking whether I should really be alive taking this drug, then the 3% is probably not worth your while. But I think this treatment is about choices and how much you can really stomach. I'm not saying you should now go and throw your tamoxifen pills away, but the benefits are there, but the benefits are also relatively small. And so there is a benefit, but as I said, there's about a 10% of risk reduction of patients. So should we give tamoxifen or should we do an aromatase inhibitor? And if you like your quality of life, I mean, the aromatase inhibitors are not making this better than tamoxifen. So these are the drugs we have. Actually, there's 3 drugs to choose from. There's letrozole and anastrozole and exemestane. All of these drugs are available, and there's never been really a study that shows that one is better than the other. There's a lot of discussion whether one drug is better than the other, but there really isn't. And whatever your doctor prescribed is probably quite all right. And sometimes what actually surprisingly, even though these drugs are really similar, like if you have a lot of side effects with one, ask your doctor to switch you. And sometimes the side effect profile is better. We don't really know why, but I've seen it plenty of time. Someone been on an anastrozole and having really bad side effects, I switch them to letrozole or exemestane, and the side effects go away. And whether this is placebo or not placebo really doesn't matter as long as your side effects go away. Who really cares what the reason is, right? These are all the trial we deal with. So these are all the studies looking at should we do tamoxifen or should we do aromatase inhibitors, and what we compared is 5 years, one versus the other. We did 5 years of tamoxifen followed by tamoxifen versus aromatase inhibitor, 5 years of tamoxifen, aromatase inhibitor, and switching here, doing this. It's like there's a lot of trials just looking at, like, should you take an aromatase inhibitor or should you take a tamoxifen? And what is the upshot of this in terms of recurrence rate? It is a little bit less likely that the breast cancer comes back with taking an aromatase inhibitor than taking tamoxifen. It is not more likely or not less likely that you're going to die from your breast cancer. So if tamoxifen suits you well, and the aromatase inhibitor is really difficult to take, by all means, stay on a tamoxifen. If you tolerate the aromatase inhibitor really well, that's your better bet. But on the other hand, if, like I say, it's like a drug that you don't take doesn't work. So what are the data beyond this? The MA17, looking at the trial, giving tamoxifen and then randomizing patient to either letrozole, which is Femara in the US, or placebo, and that's been at 5 years. That was a significant difference in terms of those who stayed on Femara had a disease-free survival of 93%, meaning like no tumor coming back in 4 years. Of 93% of women had no tumor coming back versus 87%. So that was a significant difference. So having an aromatase inhibitor beyond the 5 years of tamoxifen made a significant impact. And going back here, what actually was also interesting, so the women who got randomized to getting tamoxifen and then got nothing, after 2.5 years when the trial broke, and we knew that letrozole were better, women were allowed to then cross over and start taking letrozole. And even those who started 2 years later, even those had a benefit. So we know hormonal therapy works better, and it's also okay to take a year break. I mean, again, I'm not saying that's not what we recommend. We don't say go have a year of vacation, but if you have to have a year off because otherwise you can't stomach the 10 years, then take a year off. It's still better to take 9 years than only 5 years. So like if you want to spend that 1 year in Paris, maybe that's the time without taking the aromatase inhibitor. So these are all the trials now trying to figure out, like, I mean, what happens so we know that 5 years of tamoxifen followed by aromatase inhibitor is better, but what about 10 years of an aromatase inhibitor? And we don't have that data yet. So we don't really know whether you can take 10 years of aromatase inhibitors. Many of us do it because we extrapolate from the tamoxifen followed by aromatase inhibitors, 10 years of tamoxifen. So we stay on. We don't have that data yet. So that's all the trials that are currently ongoing. But there's one thing I want to tell you is, like, I mean, as much as I recognize the side effects and as much as I think like it's okay to take a break if you must, you also have no benefit if you don't take a drug. So that's been actually extensively studied. Unfortunately, looking at the New Jersey Medicaid data, that's looking at like who gets the drug, because we can see how often you fill the drugs. And I do drug development for a living, so I do pill counts on every patient. My pharmacist on clinical trials have you come in and then see how many drugs you have taken. And we go and check the elevator and the garbage bins and the entrance in the hospital. So we check it all, and we have found drugs everywhere through the hospital, to the degree that our flower beds actually had no flowers because our patients just stuffed the pills in a flower bed. So we know from Medicaid data, it's like, only 50% of women really take the tamoxifen by the time the 4th years come about. It's like, you don't have a benefit if you don't take the drug. And if you see here is like, the benefits of those taking the drug versus if you take the drug, the survival is much better than those who don't take the drug. It's no-brainer, right? If you don't take a drug, it can't work. So extending adjuvant therapy lessons learned. There are late recurrences. Breast cancer and ER-positive disease really can come back late. AI are probably better than tamoxifen in terms of recurrence, not with regard to death. The side effect profile is different. They have really different side effects. Tamoxifen can be given in premenopausal women. An aromatase inhibitor cannot. If you take an aromatase inhibitor, we have to make it postmenopausal. Adherence is a real problem, and the quality of life is in the eye of the beholder. So with this, thank you very much.